Ever have that sudden flutter in your chest? Or, a racing heart that seems to come out of absolutely nowhere?
Yeah, like it just goes completely off script.
Exactly. Like a Melissa student whose heart just went wild after pulling an all-nighter, or Taylor who suddenly felt dizzy, heart hammering away.
Right, and those moments, well, hiccups in the rhythm, they're often supraventricular arrhythmias, or SVAs, things starting above the ventricles.
Okay, so that's our focus today. We're doing a really high-yield dive into SVAs. What are they? How do you spot them on an ECG? What are the main types?
And we're pulling the key stuff from a great osmosis video on SDA pathology. Think of this as the need-to-know distilled version.
Perfect. So high yield. But first, maybe a super quick reminder of the normal heart rhythm. Just the basics.
Good idea. So normally, the spark starts high up in the SA node. That's the pacemaker.
Right.
It spreads to the atria, the top chambers, making them squeeze. That gives you your P wave on the ECG.
Okay.
Then it hits the AV node. Think of it as a checkpoint.
The pause button, yeah, lets the ventricles fill up.
Exactly. That's your PR interval on the ECG. Should be short, less than 5 little boxes.
Got it.
Then whiz down the main highway, the bundle of his splitting off into branches through the Purkinje fibers, telling the ventricles, the big bottom chambers, to contract.
And that's the big spike on the ECG, the QRS complex.
That's the one. And finally, everything resets. That's the T wave.
So normal sinus rhythm, SA node starts it, rates between 60 and 100, regular beat.
And crucially, one P wave right before every QRS and a QRS right after every P wave. They march in sync.
Okay. And you mentioned estimating rate quickly.
Oh yeah, the quick and dirty way. Look at the R waves, those tall spikes. Count the big boxes between them. 1 box apart, super fast, like 300. 2 boxes, 150, 3, 100. Then 75, 60, 50 gives you a rough idea fast.
300, 150, 100, 75, 60, 50. Got it. Okay, baseline established. Now, arrhythmias. What happens when this neat electrical sequence goes wrong? Well, an arrhythmia is basically any disturbance. Rate too fast, too slow, irregular rhythm, starts in the wrong place, or the signal just doesn't conduct properly. Any of those.
And how do people feel it? Does everyone notice?
Not always. Some people have no idea. Others feel palpitations like a flip-flopping or racing. Sometimes it's more serious. Dizziness, feeling faint, actually fainting.
Syncope.
Syncope, yeah. Or even chest pain if there's underlying heart disease. It's a whole spectrum.
And today we're focused supraventricular. Above the ventricles, how does that show up on the ECG?
The key is usually the QRS complex. Because the problem starts above the ventricles, the signal usually still travels down the normal fast pathways to the ventricles, so the QRS complex stays narrow.
So a narrow QRS generally points upstream, towards the atria or AV node area.
Generally, yes. If the problem starts in the ventricles, the signal spreads more slowly, cell to cell, making the QRS look wide and bizarre. Narrow QRS usually means supraventricular.
Makes sense. Okay, let's dive into the types, starting with ones that still originate from the SA node, the normal pacemaker.
Right. First, you've got sinus tachycardia.
Just fast heart rate.
Yeah, over 100 beats per minute. But critically, it's still regular, and you still see a normal P wave before every QRS. It's the SA node just firing faster.
Okay, so like exercise, stress.
Exactly, those are physiological causes. But it can also be pathological. The heart trying to compensate for something, like low output in heart failure, or maybe a blood clot in the lungs, hyperthyroidism, stuff like that.
And going too fast for too long isn't good, right? Less filling time.
Precisely. Decreased filling time, and over the long haul, it can even weaken the heart muscle, tachycardia-induced cardiomyopathy.
Okay, opposite end, sinus bradycardia.
Yep, rate below 60. Again, could be totally normal, like athletes, or during sleep.
But also pathological.
Sure, hypothyroidism, sometimes anorexia, certain heart attacks affecting the SA node's blood supply, or certain meds, beta blockers, calcium channel blockers are common ones.
The video mentions something specific to watch out for, Cushing reflex.
Ah, yes. That's a worrying triad. Slow heart rate, high blood pressure, and irregular breathing. It signals dangerously high pressure inside the skull, a real emergency.
Wow. And treatment for bradycardia if it's causing problems?
Acutely, if someone's symptomatic, IV atropine can speed things up. Chronically, if it's severe or persistent, they might need a pacemaker.
Okay. What about sinus arrhythmia? Sounds rhythmic, but not.
Yeah, the name's a bit confusing. It's actually a normal finding, especially in younger folks. The heart rate just varies slightly, with breathing speeds up a tiny bit when you inhale, slows down when you exhale. Benign.
Good to know. And sinus arrest or exit block? It sounds like the SA node just stops.
Pretty much. Either the SA node fails to fire, arrest, or it fires but the signal can't get out, exit block. On the ECG, you just see a pause, a flat line where you expect a beat.
Scary. Does the heart just stop?
Luckily, no. The heart usually has backup pacemakers lower down, like the AV node, or even cells in the ventricles that can kick in if the SA node takes a break and escape rhythm.
Phew. Okay, backups are good. Moving on to reentrant arrhythmias. What's the concept here? Like an electrical short circuit?
Sort of, yeah. Imagine the electrical signal gets trapped in a loop, like it's on a racetrack going round and round instead of finishing its lap. This can happen if there's an area of slow conduction, maybe from old scar tissue after a heart attack.
And it just keeps firing off beats independently.
Exactly. It creates its own rapid rhythm.
First big one, paroxysmal supraventricular tachycardia, PSVT.
Right. Paroxysmal means it starts and stops suddenly. Like flipping a light switch, boom, you're in a very fast, very regular rhythm, often 150 to 250 beats per minute.
Where's the loop usually?
Most commonly, it involves a little circuit within or right around the AV node. It can happen even in perfectly healthy hearts, sometimes triggered by caffeine, alcohol, stress.
And the ECG, fast, regular, narrow, QRS. What about P waves?
Usually, you can't see normal P waves. They might be buried in the QRS or happen right after it, kind of hidden.
Okay. And you can sometimes stop it yourself. Vagal maneuvers.
Yes. Things like bearing down like you're having a bowel movement, or splashing cold water on your face, or carotid massage, gently rubbing the carotid artery in the neck.
Careful with that one though, right?
Absolutely. Needs to be done properly. But these stimulate the vagus nerve, which can slow down the AV node enough to break that reentry loop.
And if that fails, adenosine.
That's the go-to drug usually.
Yeah.
Given rapidly IV, it basically slams the brakes on the AV node for a few seconds. Very effective at stopping AVNRT, the most common type of PSVT.
Any downsides to adenosine?
It can make you feel pretty weird for a few seconds, flushing, short of breath, maybe some chest discomfort, and caffeine can blunt its effect.
Oh, okay. Next reentrant rhythm. Atrial flutter. How's that different from PSVT?
The reentry loop is usually much larger, typically circling around the tricuspid valve in the right atrium. So the atria are beating very fast, maybe 250 to 350 times a minute, but usually in a very organized, regular way.
But the ventricles don't go that fast.
No, thankfully, the AV node acts as a filter. It can't conduct every single one of those atrial impulses. So you might get, say, 2 atrial beats for every 1 ventricular beat, a 2.1 block, or 3.1, sometimes variable.
And the ECG signature is classic, right? The sawtooth.
Exactly. Those rapid, regular atrial waves create a very distinct sawtooth pattern instead of normal P waves. That's the hallmark of atrial flutter.
Do vagal maneuvers work here?
Usually not. They might slow the ventricular rate temporarily by increasing the AV block, but they don't stop the flutter itself. Treatment often involves meds, electrical cardioversion, a shock or ablation, where they burn or freeze the circuit.
Okay, and the big one, atrial fibrillation, AFib. This sounds less organized than flutter.
Oh, much less organized. It's electrical chaos. Instead of one loop, you have multiple random reentrant wavelets swirling all over the atria. The atrial rate is incredibly fast, like over 500, and totally disorganized.
So the atria aren't really contracting, just quivering.
Precisely. They're fibrillating, and because the impulses hitting the AV node are completely random and chaotic, the ventricular response is also completely irregular.
That's the key ECG finding then, irregularly irregular.
That's the money phrase for AFib. No pattern to the QRS complexes at all. And you won't see any clear P waves, just a wavy or chaotic baseline. The ventricular rate is often fast too, maybe 120 to 180, but totally irregular.
Risk factors. Seems common.
Very common. High blood pressure, coronary artery disease, heart failure, valve problems, but also things like sleep apnea, obesity, excessive alcohol, the holiday heart thing.
And the big danger isn't just the irregular rhythm itself, is it?
No, the major concern is stroke. Because the atria aren't squeezing effectively, blood can stagnate, especially in this little pouch called the left atrial appendage. Clots can form there.
And if a clot breaks off?
It can travel anywhere, to the brain causing a stroke, to a leg causing limb ischemia, gut, eye, anywhere. That's why anticoagulation blood thinners is so critical for most people with AFib.
Along with trying to control the rate or rhythm?
Yes, controlling the heart rate with drugs like beta blockers or calcium channel blockers is key. Sometimes trying to restore normal rhythm with cardioversion or medications or ablation procedures too. But anticoagulation is paramount for stroke prevention.
Okay, moving away from reentry. Ectopic rhythms, meaning starting somewhere other than the SA node.
Exactly. Some other spot of the atria decides it wants to be the pacemaker, at least for a bit. If you have multiple different spots firing off, That's multifocal atrial tachycardia, or MAT.
And you mentioned a classic association.
Yeah, MAT is often seen in people with significant lung disease, bad asthma, COPD exacerbations. The low oxygen levels might irritate these atrial cells.
How does MAT look on the ECG? Is it regular?
No, it's also irregular, like AFib, and the rate is fast, usually 100 to 200. But the key difference from AFib is that you can see P waves in M and T.
Ah, but they look different.
Yes, because they're coming from different locations, you need to see at least 3 distinctly different P wave shapes in the same ECG lead to call it M and T, and the PR intervals will vary too.
Okay, 3 different P waves, irregular fast rate, got it. Last category, pre-excitation syndromes. Like Wolff-Parkinson-White, WPW, what's going on there?
This involves an extra electrical connection, an accessory pathway between the atria and the ventricles. It bypasses the normal AV node delay.
Like a shortcut.
Exactly. The most common pathway is called the bundle of Kent. People are usually born with it.
And this shortcut messes up the ECG.
It creates a classic triad. First, because the signal gets to the ventricles early via the shortcut, the PR interval is short. Second, that early arrival starts activating the ventricle muscle slowly before the main signal arrives via the normal system, causing a slurred upstroke on the QRS, it's the delta wave. And third, this early start plus the normal activation makes the whole QRS complex look a bit wider than usual.
Short PR, delta wave, wide-ish QRS, that's WPW. Is it always a problem?
Many people with the WPW pattern on their ECG have 0 symptoms their whole lives. But that accessory pathway can participate in reentrant circuits, causing arrhythmias.
Like PSVT.
Yes, PSVT is common in people with WPW. The pathway can act as part of that racetrack loop. And these episodes can cause palpitations, dizziness, fainting, and in rare circumstances, WPW can be associated with more dangerous rhythms, even sudden death, especially if AFib develops.
Wow. Okay, so let's loop back to our cases, Melissa. Late night, caffeine, then sudden fast, regular heartbeat around 200 BPM, felt faint, and it stopped with carotid massage. That points strongly to you.
Yeah, that sounds very much like PSVT, probably AVNRT. The sudden onset, regular rapid rate response to a vagal maneuver, it fits perfectly.
And Taylor, her ECG, even when she felt okay, showed the short PR, the delta wave, the slightly wide QRS.
That's textbook WPW pattern right there. And her symptoms, dizziness, racing heart, fainting diz, could definitely be episodes of arrhythmia, maybe PSVT, triggered by her underlying WPW.
So quite a range of conditions under the SVA umbrella, all starting above the ventricles, but with really different mechanisms and ECG looks.
Absolutely. And you see how understanding that normal PQRST sequence, that normal pathway, it's just fundamental to spotting what's going wrong.
Definitely. And it underscores that while, some palpitations might be nothing, if you're getting recurrent episodes or feeling dizzy or faint with them,
You absolutely need to get it checked out. Because while some SVAs like sinus arrhythmia are benign, others like AFib carry serious risks, and things like WPW need careful evaluation.
it really is an intricate electrical system, isn't it? Makes you wonder.
What else is going on in there? What other subtle variations or patterns are hiding in the ECG that we haven't fully deciphered yet?
Yeah, exactly. How much more can we learn about predicting risk or optimizing treatment just by looking closer at those electrical signals? Food for thought.
Definitely. Hopefully this quick dive gave you a solid handle on the main types of SVAs and what to look for.
I think it did. A great high-yield overview. There's always more depth to explore, but this covers the essentials nicely.